Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Okay, we are back doing SIFO Part 2. This time we're going to be focusing on treatment strategies.
Okay, so what we thought we would do is I have sort of a pyramid of my general treatment approach that we'll post with the podcast episode. And we'll just kind of start going through those different layers, how we start and what we progress to. So, I used to sometimes skip this step, which is foundations, which is making sure someone has the basics in place. We always talk about food to some extent, but I don't know that I was going into detail about things like sleep, exercise, and if they were doing anything for their stress response. So again, you just want to check in and see.
What are your foundations? Talk us through your foundations.
My foundations are sleep, food, exercise, and stress response.
What does that mean?
Okay, so sleep. We want to make sure they're having sufficient quantity and ideally quality of sleep. And if not, giving someone tips on how to do that. And so some basic tips. There's a great Andrew Huberman podcast on sleep and how to optimize sleep strategies. One really important thing is trying to get outside as early as possible after light. In Portland, ideally 20 to 30 minutes. In places where there's more sun, 5 minutes might be sufficient. So if you can't do 20 to 30 minutes, that's fine. But if you can get outside for at least 5 minutes in the early hours of when there's light, that can help set up your circadian rhythm.
Do you use a sun lamp? Would that count?
It doesn't do the same thing.
Yeah.
So ideally go outside.
Right.
Go out. You could just sit on your stoop and drink coffee. 5 minute minimum.
Yeah, that sounds wonderful.
You can brush your teeth outside. One of my colleagues posted that she does that to get outside in the morning. But you want to get your whole hormone system optimized with a little bit of early morning sunlight. That can help with sleep too. We do, of course, use medications and supplements for sleep. I always ask about caffeine if they're overdoing it. The only time I tell people not to drink coffee, because they get really mad if I tell them not to, is if they're having anxiety or sleep trouble and we think it might be related to caffeine, we'll do a trial off of caffeine.
I will just say that Michael Pollan has this amazing quote in his book, Your Brain on Plants, and it says, caffeine fixes a problem that only caffeine creates.
That's a good point. That being said, as one of my mentors had said, he had migraines. He still drank coffee. He's like, "What's life without coffee?"
Yeah, that's also.
He's a neurologist and ophthalmologist, so I'm going to go with that. Okay, so we try to optimize sleep as best we can. The other quick tips: EMF mitigation. Get a Wi-Fi timer. So it's like a Christmas tree timer for your Wi-Fi, so it shuts off the Wi-Fi at nighttime. Ideally, don't have anything plugged in within 6 feet of your bed. Have your phone on airplane mode. If you can shut off the circuit breaker to your bedroom without shutting off the fridge, you can do that. But that one is a little bit trickier.
I will also say that I bought an EMF timer for my Wi-Fi, but it doesn't work if you don't plug it in.
Yes, you do have to plug it in.
I'm just going to say that.
And it's not that hard to use because I programmed ours myself.
How do you see, like, when you're treating SIFO for people and they aren't doing these things quite as well as they might be able to, how do you see it impact treatment overall?
I think just these are the people who we keep treating and they're not getting better.
Yeah.
Like if they're chronically in fight or flight, we haven't talked about stress, they're not sleeping, they're working too much, their diet isn't, they might be following the diet per se, but it's not like a health promoting diet. They're just removing the things I used to talk too much about what are we removing, and I didn't talk as much about what we should have in the diet. So it tends to be, and exercise we know is imperative for motility, right? So if they're not doing any of these things, or, as much as we can optimizing, we're not going to get good treatment results, and we'll get frustrated. Patient will get frustrated. The doctor will get frustrated,
Okay, so that's a foundation for sleep,
Okay.
foundation for exercise.
Exercise, just do some kind of movement, ideally 20 minutes a day at least. Stress response. So if you have a patient that you can usually you can tell if they're in chronic fight or flight, it's the type of person that just they walk into the room, you kind of get a feeling that their sympathetic response is higher than we would like it to be. They'll often, if you talk about that, they'll often agree with you wholeheartedly and be very excited to see if you have anything to offer them to help with that. So the more involved programs I recommend are limbic system retraining programs like DNRS and the Gupta program. I tell people start 15 minutes a day. Don't worry that they tell you to do an hour. Just do what you can. There's lots of apps these days as well. 5 minutes of box breathing, in for 4 breaths, hold for 4 breaths, out for 4 breaths, hold for 4 breaths. Do that for 5 minutes. So there's lots of different things you can do with that, but ideally we do something every day. And then food is a very large topic, but at least ideally trying to get non-GMO, ideally organic, but at least non-GMO, and whole foods diet, anti-inflammatory diet. We'll talk more about particular food sensitivity issues, but just checking in on that and making sure they're not eating like a jar of nut butter with, I don't know, we do weird things to food these days. I had a patient who was eating this chickpea pasta and kind of trying to troubleshoot why she was not tolerating it. I said, we do weird things to food. Just don't buy things that we've done weird things to. Like we shouldn't be making chickpea into pasta. But anyway.
So is this a good time to talk about your removal trial? I know you do this dietary removal trial, or is that different?
I think that will be later on once we get to dietary modifications. Great. It's step 3 of the pyramid.
Okay, great.
Okay, so we talked about foundations. The next thing, do you have any questions about that?
Could you just read off the layers of the pyramid as like a broad overview?
So we've got foundations on the bottom, which we just talked about. The next one I was going to talk about is nutrient deficiencies and removing obvious risk factors. Then we go into antifungal herbs and medications and dietary modification, which is a very large part that we often jump to, but it is one of the most important parts. And then above that are things we sometimes need and we sometimes don't need. Motility agents, adjunct medications, hidden risk factors, and then finally, when we're getting stuck, this issue of hypersensitivity to yeast and fungal organisms.
Got it.
Okay.
That's a damn good pyramid. I just want to say, that's a damn good pyramid.
Oh, thanks. So next I was going to talk about nutrient deficiencies. So most of my information on this is from a paper called Nutrition and Candidiasis by Dr. Leo Galland from 1983. So, integrative, functional, and naturopathic doctors have been treating this for a long time. And so this was a publication he put out many decades ago that you can find online. I can try to link to this as well. But common nutritional deficiencies that he found in his patients with intestinal yeast overgrowth or a yeast problem included magnesium, B6, zinc, essential fatty acids, iron, vitamin A, and folate. And so I like to talk a little bit about, we know that a lot of those nutrients have significant impacts on immune system function. For example, if you're deficient in iron, it can actually predispose to a candida infection. You can also have too much iron, which can predispose to potential issues with dysbiosis. We know you need vitamin A for T cell and mucous membrane function. You need zinc for vitamin A to function properly, to make stomach acid, and for immune system function. And deficiencies in biotin and zinc have been associated with candidal infections.
Great.
So those are some of the main ones, and I just like to go through what we shoot for and how we test for those if we do test for them.
That'd be awesome.
For zinc, on all of my new patients, I check a plasma zinc level. It's hard sometimes to specify plasma, but whatever you can get, plasma or serum.
Do you know your range?
So typically we shoot for 80 to 100.
Okay.
And you can get that through Quest or LabCorp.
And then one more question. Do you notice that supplementation corrects these numbers?
That's a really good question. I do have a significant minority of patients where giving them zinc has been challenging to actually bump the numbers up. I haven't completely figured out why that is. If it just fails to improve, you don't necessarily need to give more. There's something else you're missing as to why they're not absorbing and utilizing zinc properly. I don't have all the answers to that one. Vitamin A, I don't usually test for. You can test for a retinol level and retinol binding protein through regular labs, but I usually just do either cod liver oil or vitamin D complete, which has some vitamin A if we think they're having an issue with absorbing fat soluble vitamins. And if they have poor night vision, that can be one indication that they might be having issues with vitamin A. Caution as always, don't give vitamin A to someone who's pregnant. It can be teratogenic in larger doses.
And it could be toxic if you take it larger doses for too long.
For anyone.
For anyone.
Right. B vitamins, again, I don't routinely test for these except for B12 and methylmalonic acid, but I often will give patients something like basic B complex or B complex number 12. If they do also have low to low normal B12 on a lab test, I just try to give like a B complex together.
And you always, is there what's your cutoff for low B12?
Yeah.
And B, do you ever do injections?
So for B12, even the regular lab reference range will say less than 400 to consider supplementation, definitely less than 200. I usually tell someone if they have B12 levels in like the 400, 500 range, it may still be worth doing a trial of supplementation, and it tells me their absorption might be suboptimal. Technically, I don't think they're going to have any long-term damage from a B12 deficiency if it's above 400. And as far as B12 shots, sometimes if it's really low, like in the 200s, I'll do B12 shots just to get it up higher. But the studies show that oral B12 in the amounts that we use, which is, in the 500 to 1,000 microgram rate, is it micrograms? I can't remember.
I think it's
but in the 500 to 1,000 microgram range, you can overcome any potential absorption issues, and it repletes it to the same extent as shots. So you don't really need to do shots. I have the occasional patient that says, I feel amazing when I take B12 shots. I would say that happens maybe 1 out of 10 people when I used to prescribe it more. So now I reserve it to when their levels are really low, or we're kind of getting stuck and we want to just try do a trial of B12 shots to see if they feel better on it. Magnesium, I almost never check a blood test. Some people say to check a red blood cell magnesium, but we know that magnesium is depleted by stress, caffeine, and loud noises. Most people are low. If they have any crampy type symptoms, muscle cramps, PMS, headaches, constipation, palpitations, a lot of these magnesium deficiency signs, I'll just supplement. I know both of you prefer magnesium citrate. I prefer magnesium citramate. It's better tolerated by my patients for whatever reason.
I just want to say, if the goal is absorption of magnesium, citrate is not necessarily a preference.
Right.
Like magnesium taurate is phenomenal for cardiovascular tissue. Magnesium threonate from the brain, glycinate for muscles.
Right.
Yeah.
So you can try different threonate.
Muscles mostly. It's just better absorbed. Some people use it more for mood.
Malate.
Yeah.
So citramate I use mostly if we're trying to work on constipation, and the other forms we'll use for more systemic absorption.
Yeah.
So again, I don't routinely check magnesium blood level. I often just supplement. It's one of the few things I tell people, you may want to just take this indefinitely. Unless you're not exposed to stress or loud noises or caffeine.
Which is everybody.
Right.
Because we live like humans.
Iron, again, it's like a Goldilocks level. Too much or too little is problematic. I will always check a ferritin on all of my new patients. Sometimes I'll do the full panel. I often just check a ferritin. And then if we think it's falsely elevated from inflammation, then I might go back and check a full panel, but I can't remember a time when I've had to do that. It's almost always been indicative of what we think is going on in the low normal range, and we aim for above 50. There's a study on women showing less than 50 was related to more fatigue symptoms. So we try to shoot for at least 50, and we are all using more iron infusions these days just because a lot of our patients do have absorption issues, menstrual losses, and other reasons for just having trouble tolerating oral iron. We know in IBD patients, oral iron can be quite detrimental.
Yeah.
So there's a great podcast from Curbsiders on iron and various forms of it. So that's iron. And that's everything for nutrient deficiencies. Do you have any questions on, so just to kind of summarize again, blood testing wise, I usually check a zinc and a ferritin. We'll supplement if low or low normal. I don't check, I just supplement with magnesium. I check a B12, often use a B complex.
Okay, so I know you also sometimes check copper. Is that for a different reason?
Okay, good point. So whenever you check zinc, you want to check copper too. Theoretically, if we give someone zinc, it could suppress copper. They kind of balance each other out. So as one goes up, the other can go down. That being said, I've never suppressed someone's copper with giving them zinc because I always check follow-up labs if I'm going to give them zinc. But theoretically, it's possible. So I do check it. I occasionally will supplement with copper only if the level is suboptimal. For that too, we usually go for 70 to 100. I don't shoot for as high with that, but you definitely want to be in the normal range for the lab for immune system function.
And then how about, everybody talks about the zinc copper ratio? Do I care about that?
I don't really use that ratio. I shoot for 80 to 100 with zinc. For copper, I only supplement if it's low.
And you're starting to supplement people before you're going into true like SIFO treatment.
Right,
You're
I
giving
do.
them, okay.
The first set of labs, sometimes I'll do it concurrently because on the first set of labs, I do usually check zinc, copper, B12, ferritin, and those candida antibodies. And then we'll put together a treatment plan. So I do sometimes treat it all together as well. But if you have a zinc deficiency, you want the nutrients to be in place so we have the best shot at for our treatment to work.
Even though absorption is likely not as optimal as it might be.
It's a good point. The only time I don't start with that is with protozoa. Sometimes with fungal or bacterial overgrowth, if people tell me they feel worse when I give them certain nutrients, particularly B vitamins, some of these organisms might metabolize some of these nutrients or use them, like ferritin, like iron, etc. So those are the times I don't supplement right off the bat. Otherwise, I've had patients with overgrowth who feel better even with suboptimal absorption of these nutrients if we start them on repletion.
Right. So just see how it goes.
Yeah. So that's everything for nutrients. And then the next part that I like to talk about is removing, or at least thinking about removing, obvious risk factors. So one, we often see proton pump inhibitors. We know this is a risk for overgrowth of bacteria and fungus. When we talk to patients, I'll often ask them, do you have a history of Barrett's esophagus, or was this just started and kind of forgotten? I'll have them check with their GI doctor if they're seeing one and ask, can we remove this or can we move to an H2 blocker? And we'll try to get that out of the way because we know that's going to potentially be problematic if it's not really indicated.
And H2 blockers have the same efficacy, but not as much risk as the PPI?
They don't have the same efficacy per se, depending on what you're trying to treat, but they do have some efficacy for the things we use PPIs for. I don't find them to have the same negatives as being on a proton pump inhibitor as far as acid suppression and the host of comorbidities we find with people who have been on PPIs for a long time, like C. diff and increased risk of community-acquired pneumonia. I haven't seen those studies on famotidine per se. So I feel much more comfortable having them on an H2 blocker than a PPI if they don't have a compelling reason. And
treating the SIFO, they might be able to get off everything altogether.
Right, because often SIBO and SIFO give people gas and belching and these types of symptoms. So reflux. So then we try to get some sense of if there's a motility issue that's hasn't been super easy for me to tell from the beginning. I know we talked about some of the centers in our area might be doing motility studies now for just to kind of give us a sense, but it's not something that I found an easy way.
You mean like wireless motility capsules or
just getting a more objective measure of whether they're having a motility problem.
Got it.
You know, so if someone has, I know you don't have to have constipation to have a motility issue, but if they have significant constipation for a long time, we could do that test where they eat beets or something like that and see how long it takes for it to come out. But I at least try to get a sense, do we need to think about motility as part of this? Sometimes the motility gets better as we treat the overgrowth and remove food sensitivities. Try to get a sense of pancreatic enzyme deficiency, as we learned from Alana we just touched the surface on that. We're going to be talking more about it, but a fecal elastase could be indicated, especially if they have diarrhea. Or if we suspect some sort of pancreatitis, to see if we need to replete enzymes. Opioids, not a lot of our patient population is on opioid medications, but we want to check on that. Current opioid use is at risk for fungal overgrowth. And then antibiotics. I've had a patient Alana and I shared, who was on doxycycline for years for, do you remember?
Rosacea.
Okay, ocular rosacea. And a lot of his symptoms, in addition to many things that were done, were likely in part due to the chronic antibiotic use. So we have patients that are on it for acne. I have a patient that I just saw who's on it for flares of acne around her cycle that I think are probably from ingesting dairy. So, we want to troubleshoot and see, is there a way? She had cystic acne. So I said, okay, we can use it for now a couple of days a month, but let's try to figure something else out.
And UTIs, I see it a lot. Even UTI prevention, people will pop antibiotics for that.
Right. So if we can figure out some other method besides antibiotics, that can be helpful. And that's everything for nutrient deficiencies and removing obvious risk factors.
Okay. Next is the doozy.
Woohoo!
Okay, wait. So we're going to break this down into A, pharmaceuticals, B, herbs, right? Or botanicals?
Yes.
Which one's bigger?
I use botanicals more. I don't love the idea of giving whatever percentage of our population that has IBS, which we were estimating
70s?
a lot.
In the 70s, yeah.
I don't love the idea of using pharmaceutical antifungals on a long-term basis for that big of a population. I mean, that's a lot of people to be using anti-prescriptions on that might be potentially contributing to resistance, and we don't have a lot of good antifungals. So I do use them in trials that we'll talk about, but I much prefer to use botanicals whenever possible if the patient tolerates them.
Let's get drugs out of the way because I'm more curious about botanicals.
That sounds good. So drugs, there's really two that have been used. There's a couple more that some of the integrative functional naturopathic doctors have used over the years. The two most common ones that are talked about are nystatin and fluconazole. Nystatin is super safe. It's not systemically absorbed. If I'm going to use one, particularly to determine if you get a clear response, you can at least say most likely this is a fungal overgrowth because it doesn't really work on other organisms to any significant extent.
So my understanding with nystatin in particular is that it has high efficacy for Candida albicans, but no other Candida or fungal species. Is that correct?
I think there's some efficacy for other species. I don't know the numbers on efficacy for particular other species in general, but we often also don't know which species they have. So if we're going to do a medication trial, I'll do that for 1 to 3 months. I don't, again, it's safe to use, but I don't like the idea of just, I try to find something else. It's more of like, if I'm not having success with botanicals, I want to try to get more specific about treating fungus because these two medications do treat fungus more specifically. I might do a trial of that. The other medication that's frequently used is fluconazole, and that is systemically absorbed. It has a lot of drug interactions.
Yes.
You have to check liver function tests. I don't like the idea of using that regularly because of potentially causing resistance on a large scale if all of us who are treating this start using it to the same extent we're using like rifaximin, for example. But again, if I've used botanicals, I've done the nystatin, and we just really think there still might be a fungal issue, I may do a trial for about 2 weeks to see.
So yesterday I had a patient who we ran stool tests. She's got chronic vaginal candidiasis, and we ran a stool test, and the only thing that really came up was fungus, actually.
Right.
And so for her, I offered her, do you want a systemic antifungal? Because we have to hit 2 different organisms that we know of.
Right. I think that's a very legitimate time to use it. It is indicated on a long-term periodic basis for recurrent vulvovaginal candidiasis, sometimes with an initial daily dose for a while and then weekly. And that, I think that is a very reasonable thing to do. We do have botanicals that are systemic, but in that type of a patient, I think it makes sense to offer fluconazole if they're open to medications and there's no drug interactions, etc., because we do need to work outside the GI tract as well.
Okay. And then herbs.
Okay.
Or are we done with drugs?
We're done with drugs.
Okay. Herbs.
So herbs, I break it down into fungal specific and broad spectrum antimicrobial herbs. There's pros and cons to both of those. So if you use a fungal specific herb and the person gets better, you know that likely it was from treating yeast. If you use a broad spectrum antimicrobial herb, like a lot of our botanicals are, if they get better, that's great. We don't know if we were treating fungus, bacterial overgrowth, or protozoa or something else, or some other benefit that botanicals might have. I do often start with fungal specific herbs because there's a couple I really like and that work well.
Which ones?
So I use Thorn SS722 a lot. The other fungal specific one I use a lot is Beyond Balance Mycorrhizae. So Beyond Balance is a company that makes liquid tincture glycerin based herbs that kids can take. They taste pretty good and you need very low dosing. So I do frequently use their product called Mycorrhizae, and that's fungal specific as well at this point. As far as broad spectrum antimicrobial herbs.
So neither one of those are a plant in particular.
That's true. Well, Mycorrhizae is a blend of many different herbs in one glycerin tincture. You'd have to look at it to look at all the ingredients, but it's low dosing of a synergistic, energetically potentized blend of herbs.
And are you using that mostly in kids or are you using it?
No, I use it in adults all the time.
And now broad spectrum herbs.
Right. So the main ones I use, Coptis has worked amazingly well for a lot of patients, and we know that has other benefits. It works for SIFO. So again, what are we treating? Hard to know exactly. I use the product Golden Thread Supreme from Supreme Nutrition, but there's many different Coptis.
Which is a high dose berberine. Higher dose.
Coptis is a higher dose berberine containing plant.
Okay.
Yes, because there's also Golden Seal and
Echinacea and Mahonia.
Oregon grape.
Right. So the one I've used the most is Coptis. And then neem. I use Malia Supreme, but I know several of you have had good success with the neem plus as well. Olive leaf Supreme, and then Morinda Supreme, which is noni. Those are the main ones that I use. I also recently have been using Candestat more.
Okay, can I slow you down just for a second? Olive leaf and Morinda, both of those are more fungal specific or more broad spectrum?
They're more broad spectrum. So they work on all different things. Again, they might work on viruses, bacteria, fungus, a host of different microbes. So it's hard to say what exactly we're treating when we use them. I'm trying to think. I know we're going to wrap up this segment, so we might talk a little bit more about herbals, but those are the main ones that I use.
Okay, so let me just do a quick sum up. Foundation, sleep, exercise, EMF, stuff like that. Nutrients, especially B12, iron, magnesium, zinc. Also look at copper, and then don't eat garbage, eat whole food, stuff like that.
We're going to talk more about. Yep.
And then we're going to talk, and then the plants.
Right.
Drugs and plants.
Mostly plants.
And we have so many more questions about those.
Okay.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.